My name is David Gardner. I'm a professor with the Department of Psychiatry at Dalhousie University. I'm trained as a pharmacist, so clinically, my focus has always been on the appropriate use of medications. And I started my career as a hospital pharmacist, but I've really moved into the teaching role as well as the research role. So I teach the psychiatry residents about their use of medications and pharmacy students and medical students. And then I do some research, and you'll get introduced to some of the research. And sitting in front of me is Dr. Chris Folkins, who is also a pharmacist by training, who's worked in hospital and community pharmacy, but now he spends all of his time doing research. Database research is a big part of what Chris does, and it's databases that are available across this province to tell how medications are being used or how other health technologies are being used and what good's coming from it and what not so good is coming from it. So Chris is going to talk a lot about what we learned very recently about the use of sedatives and the impact of sedatives in this province. And then we have a storyteller with us tonight. We have Georges Marcoux, who has been somebody I've had the pleasure of getting to know over 2 years, two and a half years now. And George is in the middle of the presentation going to come up and tell you a little bit about what it was like for him when he was taking sedatives and then what life has been like after sedatives. To get us started, the main reason we're here today doing this is because we did some research. The research made some impact across Atlantic Canada, and we were fortunate to get the funding from this thing on the right side, ACT, or Accelerating Clinical Trials. So you'll hear a reasonable amount of research today. We're really focusing on YAWNS NB. YAWNS NB is your answers when needing sleep in New Brunswick. It was a study that we've done, and we'll share different components of that study. I don't have any conflicts of interest. I don't think these fellas have any conflicts of interest with for-profit industries or otherwise. So I'll ask Chris to come up and start us off by telling us about what's happening in New Brunswick when it comes to prescription medication sedative use.
All right, thanks everybody for joining us. So as David alluded to, I want to provide just a bit of context, a bit of background information to give you a sense of what's happening with use of this class of drugs in Canada and more specifically in New Brunswick. So the first thing I'm going to talk about is this report that came out a couple of years ago from CBT-I and Choosing Wisely Canada, and it's called Overuse of Tests and Treatments in Canada. So these are things that we're overusing or using too much of. And one of the things they reported on was these sedative hypnotics or sleep aids among seniors. So these drugs are not recommended for use as a first choice among people over the age of 65 for help with sleep because they have risks associated with them, especially in that older age group. So they recommend other approaches before you would try these drugs. So that's why they're interested in measuring how often these are used in seniors, because it's not a guideline recommended practice. To review the drugs we're talking about, so benzodiazepines, Z drugs like zolpidem, zopiclone, trazodone, quetiapine. So we'll refer to these later in the presentation as BSH, so benzodiazepine sedative hypnotic. So that's what BSH means. So here what we're looking at is from 2020, 2021, the proportion of people over the age of 65 who are taking these medications that are, again, not recommended. Canada-wide, 8%. So 8% of seniors are taking these drugs. And then each one of these bars you see labeled across the bottom, that's our 9 provinces. Color-coded green bars are provinces that are below the national average. The purple bars are above the national average. 3 of our Atlantic provinces, those tend to be in the higher range. And if we zero in on New Brunswick, we can see that the number is 22.6. So 8% Canada-wide, 22.6% of seniors in New Brunswick are on these non-recommended medications. So about 3 times the national average. New Brunswick is by far the province in which these medications are used most frequently among seniors. So that's the first big thing to take away here. We're the highest using province. And this is just the same thing expressed just in a bit of a different way. So graphically, you can see, you can get a sense of it. So we're just showing sort of among a group of 100 people what it would look like. So on your left here, that's the province with the lowest usage, Saskatchewan. So it shows you maybe where we could try to get to. In the middle, we have the national average, 8%. And again, New Brunswick, 22.6%. That translates to 1 in about 4 to 5 people. So if you know 4 or 5 people over the age of 65, chances are one of them is using these medications that are generally not recommended. So just another way to sort of digest that information. And here what we're looking at is the same thing, but the trend over time. You'll see sort of a collection of 6 bars grouped together with the name of the province underneath. Each one of those bars from left to right represents the results for a year from 2014 to 2020. So the thing I want you to focus on here is on the top of each one of those collection of bars, there's a dashed red line. And for most of the provinces, that dashed red line goes down. So that tells us that over the years, over time, the usage is going down, which is great. That's what we want to see. But you'll notice that in New Brunswick, which is again the highest set of bars, the line is basically flat. So that is telling us that things are not changing and not improving over time. New Brunswick has the highest usage of these drugs, and it's remaining the highest, even though in most provinces it's going down. So that tells us an interesting piece of information about New Brunswick as well. And so this was concerning. And so we wanted to look a little more deeply at what's happening in New Brunswick. And to do that, so now I'll get into our own study results. We're using administrative data, which is routinely collected data. This is made available for research purposes through DataNB. That's where I work. It's an institute here at the University of New Brunswick. We provide access to all sorts of routinely collected data for research purposes. These tell us things like drug utilization, so prescriptions that are dispensed, hospital admissions, visits to the doctor. It also tells us information about people, like how old you are, and whether you're male or female, and just many, many things we can learn. So this really allows us to dig into what's happening in the province and who is using these medications. So here we're looking at a 1-year period. So fiscal year 2021, we call it, so April 2021 to March 2022. And we're looking at all people in the province over the age of 65 who have an active Medicare card. That's about 99% of the population. So this is including about 171,000 seniors. And these are independently living seniors. So for the purpose of this study, we're excluding residents of long-term care facilities, not because they're not important, but just the focus here was on seniors living in the community. And we're looking at this collection of BSH drugs, as I mentioned. And we measured a few different things, and I'll get into those in the next few slides. So just some raw numbers here. So in the first bar of this table, it says any BSH use. So this is the proportion of seniors who are using these drugs at any time, and it's 27.7%. This is a bit higher than the number we saw earlier at 22%. That was looking at chronic use, and we looked at chronic use as well. So chronic use is defined as having a prescription for one of these medications in 2 consecutive quarters of the year. In the province, about 36,000 seniors are using these medications on a chronic basis. Using the administrative data that I alluded to, we were able to separate this based on sex and based on age, and so we see these results here. So it differs quite a bit depending on sex and depending on age. So we can see here the numbers much higher among females. So the usage is 25.5% among females, 16.5% among males. So it's about 55% higher rate of usage of sedative hypnotics among senior females. We also were able to break things down by age category. So about 18% in that youngest group, almost 30% in that highest age group of 85 plus. So about a 50% spread between the youngest and oldest groups. So in addition to age and sex, the other thing we looked at was variation in frequency of usage depending on where people live. And what we found is that actually where you live is the biggest predictor. So even more so than age and sex, the biggest factor influencing the frequency of usage of these drugs is the place where you live. So we broke the province down in a couple of different ways. The first is by health zone. So the province is divided into 7 different health zones. And those are the larger areas sort of with the big white spaces between them that you can see here, labeled 1 through 7. And you can also break the province down into these smaller regions called health council communities. There are 33 of those in the province numbered here. So you're going to see in the next couple of slides the province divided in both of these ways. So the first is just simply looking at percentage of usage, again, of sedatives among seniors, breaking down by health zone. And this is color-coded heat map. So the darker the region, the higher the usage. And then we have the actual percentage number labeled on the map as well. And you can see there's a very clear divide. So as you move north in the province, the usage is quite a bit higher in the north. And then in the southern part of the province, you can see that the usage is higher on the east coast versus the west coast. So it's pretty clear distinction in terms of geography. And here we're seeing the same thing, but separating by sex. So we have female over here on the left, male on the right, and we still see that geographic separation. So globally, everything is higher among females, as we saw earlier, but that very clear delineation by geography exists in about the same distribution for both sexes. And now here, just breaking down even more granularly, as I mentioned, by that health council community. So now we're looking at 33 separate regions, again, separating females and males. And really the takeaway here is that if you look at the percentage of usage in each region, only one of these 33 regions has a number that's below the national average. And only among males as well. Among females, none of them are below the national average. So this really shows us that there's a lot of work to be done. Ideally, we'd like to see many more or all of these regions approaching that national average. So this in a way would be a good thing to monitor. If we were looking at reducing use of these medications, just how can we get, or how many regions can we get below that 8%? So right now it's 1, again, only among males. So we have a long way to go, and there's only room to improve. Just the last sort of visualization of this now is separating our lowest and highest usage groups. So again, we know usage is higher among females and it's higher among older age groups. So on our left here, this would be our highest usage group. So females in the 85 plus category. And then on the right, this would be our lowest use group of seniors, males in that 65 to 69 age group. And so you can see there's obviously quite a disparity. You can just see even from how dark the map is in each case. But really the thing I wanted to point out here is that if you take this this sort of best case scenario group, the males in the 65 to 69 group, on average, combining the whole province, about 18% of this group are using sedatives. That's still double the national average. So this is the best case scenario group, and they're still twice the national average. So this really does show us that New Brunswick is behind by quite a bit and has some improvements to make. So the last thing I wanted to touch on is that this is not without consequence. The high usage of these medications, they're not recommended for use as first-line treatment for a reason, because there are negative health consequences associated with their use. And so we looked into that a little bit using hospitalization data, and this really does illustrate the potential consequences here. So here, what we're looking at are seniors who are using specifically benzodiazepines, so that the B part of BSH, which is the most common group of drugs in the BSH category. And we're looking at hospital admissions for hip fractures, and then globally for any type of fracture, and for falls. And we're comparing seniors who use these drugs and seniors who do not use these drugs. And so if you just take a look at these odds ratio numbers here, the way that you read this is the first one is 1.74. So seniors who take benzodiazepines have a 74% higher chance of being hospitalized for hip fracture compared to seniors who do not take these. And then if we look at any fracture, not just hip fractures, 92% higher amongst seniors who use these medications. And hospitalized for a fall, which as some of you probably know, can be a very disastrous thing in terms of health consequences, 94% higher among seniors who use these medications compared to those who do not. This really shows us there's some really tangible, really real world consequences, both for health of individuals and our healthcare system as well, associated with those high usage numbers that we're seeing across the province. So just to review, New Brunswick is the highest use province for these medications. It hasn't gotten better over time in recent years. This usage is influenced by age and sex, higher among females, higher among older individuals, but even our best case group, the younger males, are still double the national average in terms of usage. An even greater influence is where you live, right? So that regional variation that we saw, this is the strongest predictor, gives us some insight into maybe where we would want to look in the province if we were looking at making targeted improvements. And then the last slide we saw, of course, is those negative health consequences. So I hope that sets the stage, gives you an impression of the nature of the problem, where we're at now. And David's going to talk a little more about where we go from here.
And he did make it clear that sedatives or sleeping pills are not actually first-line therapy. So cognitive behavioral therapy for insomnia is a psychological and behavioral intervention, which is first-line therapy for insomnia. And I bet you most of you are unfamiliar with it, or maybe don't even know that it exists as an option for insomnia. And there's a lot of different reasons for that, but I want to get rid of all of them so that you become familiar with it today and you can help us share the word around first-line therapy and help people access it. What I'm going to talk about next is our study to try to reduce the use of sedatives while helping people get a better sleep. So this is the YAWNS NB study, Your Answers When Needing Sleep in New Brunswick. We did what's called a randomized control trial with 3 groups. And so you see the 3 groups. One group is called the Sleepwell group. The other one is the Empower group. Both of these groups received a package in the mail. So in the mail, there was the Sleepwell package had 2 booklets as well as a cover letter. The Empower group received 2 booklets, one about the sleeping pills and one about a way to get a good night's sleep. This first booklet had actually been studied before and was shown to be effective at helping people know how to come off their sleeping pills safely. And then the third group had to wait for 6 months. The only thing we did in this study is send out packages by the mail. We didn't train the physicians differently or the pharmacists differently, or we didn't call people weekly to see how they were doing. It was send something out in the mail, very simple, and step back and see if anything changes. The booklets themselves are intended to support people to make the behavior change, to rethink their use of sleeping pills and go about reducing their sleeping pills, working with their physicians or their pharmacists or however they decided to do it. We weren't dictating it. The booklet said, please seek out your physician's advice, seek out your pharmacist's advice, and work with them to come off of their sleeping pills. This is who was involved in the study, 565 people. And I'm just going to point out a couple of things. Average age is 72. Age range is 65 to 92. They were taking their sleeping pills, their prescription sleeping pills, for over 11 years on average. And you can see that there's a really wide range there. And about a third of them had had a fall in the previous year, and some of them had quite an injury associated with that fall. The Sleepwell intervention was new, and we used something called behavior change techniques, giving people a few different things. One, the capability of reducing and stopping sleeping pills. If you didn't know how to do it before, after reading this material, you would know how to do it. And we gave people some motivation to do it. So you can look in the booklets yourself to see what we used as behavior change techniques, but some of the things that we shared were indications of the potential risks of taking these medications. And Chris just talked about some of them. But one of the risks that people really are concerned about is cognitive impairment associated with taking sedatives. Memory impairment. If you take some of these sedatives, it actually makes it difficult to remember what you have done. We also pointed out the medications are second line, not first line. So we wanted not to say we want to take something away. We want to replace it with something better. So here's what we found. And we were really pleasantly surprised by just mailing out packages, calling people up 6 months later and seeing how they're doing with their medications. 26% that received the Sleepwell package had completely stopped. Remember, it was 11 years of use. And another 20.4% had substantially reduced their dose. It was a little less with the Empower group and substantially less with the treatment as usual. This last group received the Sleepwell package after they left the study. So everybody got the package, but this is an important thing because I'm going to refer back to that in a moment. We referred people in the second Sleepwell booklet to different techniques that are cognitive behavioral therapy. And we talked about CBT-I in the booklets, and we referred people to a specific book written by a Canadian psychologist that is CBT-I. You read the book and you learn all about CBT-I. So that was a specific recommendation. More people were using CBT-I techniques by the end of the study who were in the Sleepwell group, and their sleep was actually better, and their daytime functioning was actually better. So we were very pleased with the final results. People were reducing their use of sedatives substantially, and they were also getting better sleep. So now we're trying to talk about how to scale this up across the province. And we've been meeting with government, and we've been meeting with physicians and pharmacists and otherwise to get that across. The latest data that I'll just mention really quickly is what happened to people after the study. So I worked with Chris, and we looked at the databases of dispensing records for the participants in the study. And I was concerned that after you leave the study, after your use has gone down, your use would start to go back up again. You're outside of a study, nobody's watching anymore. And so that's not abnormal. We were hoping maybe it would be neutral. We weren't expecting it to go down. But what we saw was super encouraging. Before the study, 12 months before the study, the three groups weren't showing any reduction. You wouldn't expect it to. As people came into the study, the people that received the Empower package or the Sleepwell package, they weren't starting exactly even, but they went down. And then this green group, that was the treatment as usual group that got the Sleepwell package at the end of the study. You saw after they left the study, we mailed them the package, and then you see a substantial reduction in their overall use. So that reassures us that it's not just in a study it works, but it can work outside of a study as well. The takeaways are this set of booklets reduces reliance on sedatives, helps people to kind of take it on their own as a self-help approach to improve their sleep and daytime activities. And it seems to have a sustained impact. After the study was over, we followed up for 12 months, and there wasn't an increase in use of sedatives. So that's reassuring to us. We're going to have George tell us about his own personal experience. He and I came to know each other through this clinical trial that I just told you about, and then I'll come back up and give some practical tips after that.
People will ask if I'm paid to do that tonight. If I would be paid, I would be in the Bahamas, not in Fredericton. What happened that I took a sleeping pill? Just to put you in context, we moved from Quebec to back to Bathurst, and when I got to the office the first day, on the wall there was a red phone, and on my desk there was a black phone. So I asked my assistant, what is the red phone for? She says, well, when the big boss calls, he calls you on the red phone, so you better answer. And so I started thinking about when is that red phone going to ring? I couldn't sleep. Geez, I was seeing that red phone. It was just out of... So about 7 to 8 months I was in that job. I went to see my doctor and I said, listen, I can't sleep. So it took about 5 minutes, and he gave me a sleeping pill, which was... oxyzapine 30 milligram. So I started to take that. Never asked me any question, and over the years I never asked if I should stop. So I took a sleeping pill for 35 years. And when I was taking that sleeping pill, from what I can remember, is, for example, if you take a sleeping pill at midnight, that sleeping pill will still be active next morning until noon. So when I woke up in the morning, I was grumpy. I couldn't put my ideas together. And then I was taking the car to go somewhere. So I continued. I never asked the question. So we changed doctors, never asked any question. So one of the things that I was thinking about, and the reason why I decided to when I saw the YAWNS study, in my family, I have 5 brothers and sisters that died of Alzheimer's. And the more I was reading, the more I was looking at my brain and say, listen, if I don't want to get Alzheimer's, that's for sure. I'm not going to get Alzheimer's. So one day I was reading the local newspaper and I see this little article that they were doing a study on people that were taking sleeping pill. And I said to my wife, I think I'm going to get involved in that. So I got involved, and the more I read their documentation, the more I understood that that was the right way to go. But there's one thing, is that you need a commitment, a very strong commitment to stop. So after a series of literatures that I read a book, Sink Into Sleep, and I read the book, and it was funny because she was exactly saying the same thing that I saw in the other documentation. So what I did is I prepared a program because I was 35 years with the pill. You remember 35 years, one pill a day, 365 days a year for 35 years is a lot of pill. So I did a program to stop the sleeping pill over a year. And I went to see my pharmacist and I said, Vince, here is what I want to do. And I remember him telling me, George, you will find how better you will feel if you stop that when you get older. I'm older today, but as I get older. And then I went to see my doctor and she agreed with that. So I started to do that. So what I did is every 3 months, I was changing my dose, reducing my dose. And for the first month, I was analyzing my sleep. Like in the morning, I would wake up. How long did I sleep? What time did I go to bed? What time did I wake up? Did I wake up during the night? What was the reason I woke up? So I was analyzing the sleep. So and then I was progressing. I was seeing that I was getting a little bit better all the time, up to the time that I will call this my biological clock. Today, my clock says 10 o'clock, 10 to 10:30, you got to go to bed. And you will wake up at 7:30 in the morning. That's what happens. And I usually wake up during the night, but that's okay for about 10, 15 minutes. If I wake up too long, if I'm in bed too long without sleeping, I get up. I'll go and read something and then go back to bed. So don't look at the TV. See, that's not good. Just read. So I think that if I would give you a rating from 0 to 10, 0 where I was and 10 where I am today, I'll give myself 10 because first of all, my health is 100%, my memory is 200%, and I'm telling you, I had a few accidents that happened when I was taking those pills because I was wondering if it was those pills or not, but it was. I can tell you I said to my wife about a month ago, listen, I think what I'm going to do is write the story of my life. She started to laugh. She said, you tried that 3 years ago, you couldn't do it. That's true. I started that 3 years ago. I started trying to remember things I could remember. I started that a month ago, and I know the dates. I know what happened. I write it down. I'm up to 20 pages. So I mean that means that my memory is clear. I have no more sedative whatsoever. And I'm telling you, 10 is, I should have 15 because really it's a gift I made to myself because that's exactly what I wanted to do to get rid of it. I've been off that pill now for 2 years. But in order to do that, you need to have a very strong commitment to do it. And if you need somebody, you need perhaps somebody to help you going through the process. And I think that these people exist, whether it's your pharmacist, your doctor, people that can help you. Over the last 2 years, I've been giving conferences across the Brunswick to senior groups. And you cannot imagine how many people ask me the same question. How did you get out of that? And I put the CBT-I and I said, listen, follow these things, follow it. If you need help, we'll give you help. But CBT-I is, compared to the pill, it's like 1,000% better. And I just want to leave you tonight by saying the person you see in front of you, if you had seen him maybe 5, 10 years ago, you see something happened to it. So I'm 80 years old and I want to live another 40, I hope. So please, if you're going to take the word out to the people and say, listen, you have to understand exactly the causes of a sleeping pill. Thank you.
So we'll come back to talking about CBT-I specifically. And I just want to point out Jill Stever is in the audience. Put your hand up, please, Jill. Jill is a very unusual person in that she offers CBT-I as a therapist. And we don't have enough Jill Stevers in Canada to treat everybody who has insomnia. So I'm going to talk about the approach where people can do a self-help approach. And if that doesn't work out, then you may try a different self-help approach, or you may be able to connect with somebody who does have the ability to provide you as a therapist with CBT-I. But for us to make CBT-I available to everybody, we need to make it so that it's simple and easy to access. And so that's what I'm going to focus on. So the first thing we need to talk about is, why do people have insomnia that gets chronic and you just night after night after night live with it? And I'm sure everybody here knows about Pavlov's dogs and this association kind of thing, right? So who here likes to go to the dentist and feels loose as a goose when they arrive, compared to maybe feeling physically tense, not wanting to get that shot? That's the last thing. It affects your mind and it affects you physically. You become tense. Some people actually become nauseous because of it. So our mind and our body are together. In our house, my dog barks so loud when the bell rings that when the bell rings and my dog's not in the house, I still get tense and I feel irritable because somebody's come to the door, not because I'm antisocial, but because of this learned relationship. And this is what is happening when people are saying, oh no, it's bedtime. I'm going to be getting into that bed. I hope tonight that I'm actually going to be able to get to sleep. That sentence that I just said is you're not ready for sleep because you just said that to yourself and you're already worrying about sleep. And you know that when you turn the light off, your mind is going to start racing and your body's not relaxed at all. It's not ready for sleeping. So I want us to think about it from that perspective. A sleeping pill is not designed to help with any of those things. So you're not going to overcome those issues using a sleeping pill. I also want to talk a little bit about sleep pressure. So we have a circadian rhythm that helps us get ready for sleep, and we have something else known as sleep pressure as the other component, as our biological rhythms that help us get ready for sleep. So you wake up and your sleep pressure is at its lowest point, and it just builds up over the day. And when you get to bedtime, your sleep pressure is usually high enough that you're ready to fall asleep if you don't have insomnia. But you can do things if you have insomnia that rob you of your sleep pressure. So adenosine is a chemical in our brain that builds up and helps us in terms of our brain activity get ready for sleep. Caffeine is a blocker of adenosine. When we don't sleep well, we often overdo it with caffeine the next day. So that's a natural way for us to undo our sleep pressure. If we nap, our sleep pressure actually goes down. Who here falls asleep watching TV at night? You're robbing yourself of sleep pressure if you're watching TV or doing something else and letting yourself doze off. Oh, I get dozy. I'm getting closer to bedtime. I'm just going to let myself doze off. And then you go to bed. And when you get into bed and turn the light off, your mind's racing. You've kind of stolen a little bit of that sleep pressure because of the dozing before bed. So a great idea is to not let yourself fall asleep before bed. If you're going to nap, move it really early in the day. Ideally, don't nap if you can. But if you do have to nap, 15 minutes before 3 o'clock is a good rule to follow. If you're not ready for falling asleep, sometimes it's 11 o'clock and you say, I go to bed every night at 11 o'clock, but for some reason tonight, I'm not tired. Please don't go to bed. Because what are you going to do in bed? You're going to lie there and you're going to go, tomorrow's going to be a rotten day. I hate myself for lying here in bed. I'm thinking bad thoughts about me. I actually think my brain is broken. What is wrong with my brain? You go through all of these thoughts while you're lying in bed and your body tenses up and your brain's hyperactivated. You're not ready to sleep. So please stay away from your bed if you're experiencing any of these things. So a big part of CBT-I is actually spending less time in bed. And very often that means staying up later, at least at the start. And then you earn some time back because you're sleeping better. The continuity of your sleep is better. It's less fragmented and it feels more fulfilling, even though it might not be a lot longer because of what you've been doing. So let's go back to the sleeping pills and then we'll look into the CBT-I a little bit more. What do you get from sleeping pills? The best studies on sleeping pills show us that you're getting to sleep faster than taking a placebo pill by about 8 to 16 minutes. And you're sleeping longer by somewhere between 5 to 23 minutes. That's what you're getting from taking sleeping pills. You're also getting these potential concerns. So we've already talked about the risk of falls and serious injuries because of that. I've mentioned that some of the impairment of your cognitive functioning. There's some immunity issues that can come with some of these sleeping pills, increasing your risk of complications from the flu or from COVID. And we also know that what was already mentioned by George and others is that some of the sleeping pills actually affect your driving in the morning. Canada's most prescribed sleeping pill is Zopiclone. It impairs your driving 11 hours after you take it to the same level as if you had a blood alcohol content of the legal limit. 11 hours. And then they cause a withdrawal reaction. And the most common symptom of the withdrawal reaction when you stop them abruptly is insomnia. So you think you're still needing them because you're having withdrawal-related insomnia. CBT-I is a completely different approach. CBT-I is a collection of effective interventions working together. And this is what George was talking about. You have to commit to this, but it's 5 different components. The one on the right side, sleep hygiene, is the least important for chronic insomnia. The other ones are way more important, particularly the behavior change ones, which are the first two, and I'll just get into those a little bit. So if you're curious about how CBT-I is different than sleeping pills, there's a handout. If you didn't get any of these handouts that I'm going to show you, they're all on the website. They're free. You can print them off, and they're available in both English and French. A typical treatment course for CBT-I is about 6 weeks long. Some are 4 weeks long, some are 8 weeks long. But if you follow the program, you are done after 8 weeks. And George, you were done after 35 years. Very different approaches. The cornerstone of CBT-I is using a sleep diary. So a sleep diary is you in the morning writing down how last night's sleep went. The questions are relatively simple. Just don't get caught up in getting it exact. So what time did you go to bed? Was it 10:05 or 10:05 and a half? Nobody cares. It was about 10. It was maybe about 10:15. How long was it once you turned the light off until when you went to sleep? Well, how am I supposed to know? I wasn't looking. Please don't look at the clock. Just guess. Okay, I think it was about 45 minutes. I'm not sure. Write down 45. It doesn't matter. You're just going to be following trends over time. This is the cornerstone of you being able to see how your sleep is changing over time and identifying some trends or some issues in your sleep patterns. They come out in the sleep diary. So here's some insights as to what you might do with one of the components. This is called, fancy name, stimulus control. We just say you're in control, so we call it control. So try not to nap. I talked about that. Set a bedtime and set a rise time that you can live with 7 days a week. So if you think you want to get up at 6:30 every morning, that's when you get up, even if you've had a terrible sleep. And if you say 11:30 is my bedtime, and it's not when you're tired, don't go to bed. If you're tired before that, don't let yourself fall asleep. When you go to bed and you realize it's probably been about 20 minutes and I'm not asleep, please leave the bed. And if you have the ability, leave the whole bedroom, if that's your setup. Not everybody has that as a setup, but get away from the thing that you have a bad association with that causes the mind to race. So this is different than sleep hygiene. Sleep hygiene is make sure that the temperature of your room is right, it's quiet, that the bed is comfortable, that you didn't eat too much chocolate or coffee that night, you exercised in the morning, you got a lot of light in the morning. Those are all really important things, but this is a bit of a different thing. It's your behavior being changed related to when you're going to bed and what you're doing if you're not asleep in bed, you're leaving the bed. So just to get an introduction to some of these techniques, we have a page that you can print off from our website called 10 Tips for Better Sleep. That list is not all of what CBT-I is. It is an introduction to CBT-I, and I will let you in on a secret. A number of my colleagues who are primary care physicians and pharmacists, they say this works well for quite a few people. And if it's not enough for you, then you move on to a CBT-I program. So just letting you know that you might find these tips to be quite helpful for you. I'm going to show you some evidence because you're going, oh, who's this guy? Guy came from Halifax. Can't trust people from Halifax. So I'm actually just going to show you some of the evidence. There's literally hundreds of studies I could share with you. This is a study with people who have insomnia and pain. So I just bring this up because it's not people who have perfect health and insomnia. It's people who have all sorts of health issues. I mean, mental health issues or physical health issues or both, and also have insomnia. So this is one study where people had fibromyalgia. They were adults somewhere in their 40s, and they learned CBT-I, or they learned cognitive behavioral therapy for pain, or they didn't do anything. And what they showed is that the people who did CBT-I for a few weeks, 70% of them said, I no longer have insomnia. So that was, for our healthcare interventions, from our perspective, that's a very effective intervention. I'm not showing the data, but they also showed that the patients who did the CBT-I had better long-term pain outcomes, not just insomnia outcomes. This is another one that shows CBT-I versus a specific commonly used sleeping pill, prescribed sleeping pill, and placebo. The 8-week treatment improved the sleep impairment index more so with CBT-I compared to the sleeping pill. And then as you follow people up, the treatment ends right here for CBT-I. 3 months later, 12 months later, 24 months later, the sleep remains improved. It never gets that good with the sleeping pill. What we're trying to do is have people become aware that there are things that they can do in their behavior and in how they think about their sleep. So behavioral therapy and cognitive therapy to improve their sleep so that they don't have insomnia anymore. So we're trying to move people out from seeing their family doctor and getting a sleeping pill to doing it on their own. Of course, there's going to be some people that it doesn't work out for them. And so they'll go and see a family doctor and get a referral, and somebody might get referred to Jill, for example. But ultimately, we want to show that there are effective approaches that you may not yet know about and try for yourself. And as George says, it can work really well as long as you're committed to it. So this is why we developed something known as Sleepwell. So if you haven't visited our website, mysleepwell.ca basically provides you with all of the tools and everything that I've said and the recommended resources for you. It's both English and French, Sleepwell Mieux Dormir, and it's our way to take what we've learned from research, not just our research, but everybody's research. CBT-I has been developed over decades. It's not brand new, but it's become available as a self-help resource much more recently, and that's why it's become a lot more feasible for people to actually access. So you go to our website and you can learn everything that I've just said that you forget as you go out the door. I always forget what people say during lectures. And if you do, as long as you remember mysleepwell.ca. Over the last year or so, we've had a lot more people visiting. So word is getting around. We're having this month, we had 15,000 visitors taking advantage, and we have thousands of people downloading our resources. So I just want to let you know that it's going well, and we're just researchers. We're not advertisers. And so it's a lot of the word of mouth. The sleeping pill information is there. You can click on it and learn more about sleeping pills, stuff that you've heard me talk about. What George was talking about, though, is gradual dose reduction. If you are taking a sleeping pill, it's not recommended to stop it quickly. How you stop it, it's kind of up to you. George did it one way. Other people do it in a few short weeks, some people even faster. But we recommend that you work with your healthcare provider to gradually reduce the dose. And sometimes it goes a bit slower right near the end just because it can be a bit more difficult. And so we go more cautiously. So gradual dose reduction. You can also do CBT-I while you're coming off of your sleeping pill to give you yourself a better sleep while you're coming off of your sleeping pill, and work with your healthcare providers. So where do you start with insomnia treatment? So if you're leaving here today, here's where you might want to start before you go towards a CBT-I program: the 10 tips and the sleep diary. We have copies of something we have not studied yet, so it's not actually available. But if you're interested in being a participant in our research, please let me know so that we can, as we do our next study, which would involve the CBT-I workbook, you may be a participant in that study.
There's been a few questions about stopping zolpidem, and as you mentioned, David, it is a popular medication choice. I think it was covered a little bit, but can you speak to folks that are trying to deprescribe or maybe taper their medications, and at the same time, should they start CBT-I? Who should folks talk to, I guess, about their tapering regimens if they have concerns?
The pharmacist and the prescriber are critical helpers with this. It really is led by the person who's reducing the dose with the motivation and the commitment to it. And the pharmacists and the physicians or the other prescribers, nurse practitioners, they can really support the person going through that process. And if there are any potential withdrawal symptoms, they can say, you might want to go back up on last week's dose and stick with that for a little bit. The pharmacist also knows a little bit more often about how tablets can be split. So if you're taking zolpidem 7.5 milligrams, it's a bit funny of a shape. It's not the easiest thing to split into half or 4, but the 5 milligram circle tablet, that can be split. And we're not looking for it to be split perfectly. So you split it or you get a little knife out and it's not quite perfect. That's totally okay. So you can even come down to 1/8 of a 5 milligram tablet when you get to that point in it. The question around when to introduce CBT-I is, it falls back to, when would you like to do it? Would you like to work on your sleep first before you start to reduce your dose? Or do you want to just start reducing your dose and see how it goes, and then start to add CBT-I techniques in if you start to notice that your sleep is not doing so well through the process? And we say some people come right off the medications with a gradual dose reduction without using CBT-I, and then later have some troubles with sleep, and then they can introduce CBT-I at that point. So it's really up to the individual. We just did some work on CBT-I for menopause. There's a robust literature on the effectiveness of CBT-I for menopause. I can verify for you it's as effective as I just showed from other studies. So I want to make sure that we're not saying you need to be using sleeping pills to benefit from CBT-I. CBT-I is effective for people that have nothing to do with sleeping pills, that have insomnia. So we would start ideally with somebody who is having a reason for their insomnia. It kind of doesn't matter what the reason is, but a very common reason is perimenopause or menopause. And that's where we would say, all right, what do you need to do to focus on your perimenopause, menopause symptoms? Take care of those in the way that's optimal to take care of those, but don't forget to directly treat insomnia with CBT-I. And if somebody has two types of sleep disorders, like sleep apnea, or a different type of sleep disorder, where they have a sleep disorder that might be related to a developmental issue, and we call ADHD a developmental issue, there are specific therapies that are effective for insomnia related to those. CBT-I can be certainly beneficial. So who here has heard of melatonin? Everybody in the room. Melatonin is valuable, at least in young people, children, who have ADHD and sleep problems. I don't think it has been studied in adults with ADHD, but I'm telling you where the evidence lies. I'll also mention that melatonin has been studied in adults with insomnia not complicated by other things and shown not to be effective. So I'm suspecting that some people here have tried melatonin and are still frustrated with their sleep. And that's because melatonin's effectiveness in these very good studies in people who have insomnia, it's as good as the placebo group, the pill that is just a sugar pill. So we do have a place for melatonin in sleep problems, but not really for run-of-the-mill average insomnia.
Yeah, I was just going to quickly interject if I could. I went to an online presentation today by Dr. Pauline Mackey, who's quite well known in the menopause space for all her work on cognition and sleep issues. And really, she did, reiterate basically what you were saying, David, around, if someone's having vasomotor symptoms or hot flashes at night, certainly speaking to your healthcare professionals about that in terms of nighttime awakenings, which are very common and probably one of the more common problems for folks with perimenopause and menopause. But she did encourage to talk about having your symptoms approached and managed because they may be contributing, but also that we're now learning that it isn't all just about vasomotor symptoms for folks who are experiencing perimenopause and menopause. So I think you're going to see more work coming, thankfully, in this area for midlife folks with ovaries. And I think we're starting to, see different things possibly happening with the pathophysiology related to sleep. So I would say, keep your door open for more information in the next few years coming in this space. But certainly agree with what you were mentioning there about, helping with symptoms and things like that. But she strongly still recommends CBT-I as the first line approach.
We don't have, sociologists or behavior scientists coming in and saying, why are we different than other parts of Canada? I really do think it's more sociological. It's not necessarily a distribution of the illness is greater in New Brunswick. I don't think it's to do with that, but I do think it's to do with just what's become the norm. And I think the norm has become that we use sleeping pills for insomnia, and the sleeping pills can be habit forming. And so once you're on the sleeping pills, it becomes very obvious because you've got hundreds of people taking them for years and years. Physicians see each other having lots of patients on sleeping pills, so it becomes the norm to have patients on sleeping pills. And family members see their loved ones taking sleeping pills, so that becomes the norm for them. So I do really think it's more to do with our culture. We're a bit more permissive with the use of it because we have this history of higher use. And it does make it a bit more challenging. So we all have to kind of work together to raise the awareness of some of the concerns as well as the alternatives going forward. So now that we have all of this information to back up what we suspected or what we were concerned about, and we have, I think, good ideas of what we can do about it, we need to all work together to go forward. So last Friday, we had a really positive meeting with government. And this Monday, we had a really positive meeting with New Brunswick's Medical Society. And we've been working with the Medical Society already, but they didn't expect to see the numbers that they saw. And so they are ready to have a follow-up meeting with a presentation that's bigger to really get engaged and figure out what are we going to start to do. It's not going to change overnight. We're not going to be able to do it overnight, but I feel like we're trying to line up all the people to work together. George wants this taken care of today. He keeps talking about action, and I really appreciate him holding our feet to the floor. But it does take the community, the public, the patients, the physicians, the health planners, and the decision makers to all recognize this as an issue and be supportive of what direction to go in. And that's what we're trying to do. That's why I'm here to try to do that. The booklets that we made and studied, our colleague was an interloper and he shared it with people in Iceland. Our Icelandic colleagues really liked it. We translated it to Icelandic with them. They sent 20,000 copies to every family doctor clinic and office and to every pharmacy. So it was a passive one. We sent it directly to the patient. They sent it to where the patients end up. So they did it a different way, and we'll find out if that made a difference because they're like New Brunswick. They have a very high rate.
A couple of folks are asking about sleep apnea. And I guess in the realm of still struggling, even though using CBT-I, but if you have sleep apnea, but they're still experiencing challenges, is there any additional advice that can be given?
Yeah, I think the straightforward advice that I pass along because I've been hearing other sleep experts who work in the area of sleep apnea talk about it is it's very possible for somebody to have insomnia as a diagnosis and sleep apnea as a diagnosis. And there are two ideal ways to treat them, and they're not the same. So you need the ideal way for treating sleep apnea, which is CPAP or something similar to CPAP, and the other is CBT-I. So you'll get a better outcome if you're treating both sleep disorders optimally. On our website, we have a variety of different CBT-I resources. So the website page is Sleepwell Recommends. It includes a map of providers, but the map is far from complete. And we can add that some people offer it virtually, so you don't have to be co-located. You don't have to be able to walk down the street to find your therapist. There's a lot of people who are not in New Brunswick who are actually available to New Brunswickers for CBT-I as well. So we could add that to it. I think of it as it's really about that whole association with being in the bed, and the overall approach is kind of similar. So if you've got a reason that keeps you up at night from a physical health issue or a mental health issue, whether it's tinnitus, whether it's endometriosis, whether it's diabetes related issues, whether it's anxiety, even schizophrenia has been studied with CBT-I. Please don't go off a cold turkey. And if you choose to go off a cold turkey, please don't say, I heard David Gardner talking and that's what he said. No, we recommend people follow a gradual reduction in their dose. So this actually says weeks, and for some people, months. So for George, it was close to a year for him from where he started until he ended. If you have been taking a sleeping pill, anybody has been taking a sleeping pill for several weeks, we don't recommend cold turkey. For people who have been taking it several months and years, we recommend a very gradual dose reduction approach. If you've been taking it for 4 or 5 days, that's where we're not so concerned about a significant withdrawal, rebound, insomnia, and other kind of problem associated with it. But most of the people I end up talking to when they tell me how long they've been taking it, I know it's going to take them weeks at a minimum and sometimes many months before they comfortably come off of it. So during that process, that's going on, you're supported by your pharmacist, you're supported by your prescriber. During that process, you can think of, I can get my sleep back now. I don't need to wait until I'm off the sleeping pills. I can start to work on that now. And that's why you can choose when you want to start CBT-I. And as George said, he used a specific book, Sink into Sleep. There's other resources out there that you could use to start. And if that makes you feel confident in starting to come off sleeping pills, that can be an actual benefit of using CBT-I early.
The number of hours, I guess the amount of time that you need to be sleeping.
7.645 has been proven to be the best amount of time. There isn't a right answer for that. So this idea of 8 hours, somebody who needed 8 hours put that out there and made it the number, but it's not 8 hours. And I'm sure some of you have ever had the experience of 6.5 hours one night was all you needed, and 8 hours another night didn't do enough. So it's never the same within a person, and it's never the same across people. Some of the guidance says 7 to 9 hours is, for most people, a good amount of sleep. But I certainly can sleep well and function totally well with a lot less than that. But maybe I wouldn't want that every day. But I've worked with people who are short sleepers. They were born to be short sleepers, and they will get away with 5 hours, 5.5, 6 hours. And I don't know how they do it. They get so much more done than I could ever imagine, but they seem to be okay. And then there was that thing about the Blue Jay pitcher from a year or two ago. He slept for 13 hours, and he said it's not a problem. So that's why the number itself is less important than how you feel the next day after your sleep. Penny Corkum. Do you know Penny Corkum? She's a psychologist, researcher, specialist in sleep. She's at the IWK in Halifax. And she has a program called Better Nights, Better Days. So you can look it up on the internet. And it's focused from, very young infants all the way through the years. So she's been working on, from the research side, translating it into practical tools. So that might be a place for you to start. I know that tracking sleep using a sleep diary can sometimes make people just a little bit anxious to get it right. And that's why I said, don't worry about getting it right. I know that smartwatches can make that tenfold higher. My smartwatch makes me really focus in on, have I got the ideal perfect sleep yet? That phenomenon is known as orthosomnia. And orthosomnia is this fancy term to just basically say you're way over worried about getting the perfect sleep and you're trying to chase it through your watch or your fancy ring or your phone. So we go old school when it comes to managing insomnia, and we strongly recommend try not to use any fancy electronic advanced device to dictate how you think you've been sleeping. It's often not what the machine is telling you, but it's what your feelings are telling you about how well you're sleeping. And that's what insomnia is. It's subjective. It's not dictated by any kind of fancy machine. I think the easy answer is ask your pharmacist what they're capable of doing, and if they need to contact the prescriber to make some of the adaptations to follow the law. It depends on if it's a controlled drug, and it depends on what province you live in, or if it's a prescription drug and the scope of the pharmacist's practice. So there's some variations from place to place, but your own pharmacist will know the rules that they're governed by in that sense. And to go back to the zopiclone, as I mentioned earlier, some of the tablets are quite easy to split, and I quite honestly think you can easily get the 5 milligram tablets, take 1.5 of those, and that's 7.5 milligrams, which you might currently be taking, and then you can get it down to 5 milligrams or 6.25 milligrams, and then cut it down, however you want to do it, what works for you. So a pharmacist can give you advice on that, but I tend to say, as long as it looks close to 1/4 or close to 1/8, you're cutting it down in a gradual way, which is what we're recommending.